Yesterday, I presented a poster on the topic of cardio-oncology and prostate cancer, where we were looking at baseline hypertension, hyperlipidemia, and diabetes in patients that were treated at our institution from 2020 to 2025 who had advanced staged prostate cancer that were receiving androgen deprivation therapy as well as a novel hormonal therapy agent. So those agents included Abiraterone, apalutamide, enzalutamide, and darolutamide. So at our institution, over this period of time for this group of patients, we had about 87 patients in the Abiraterone group and 80 patients in the darolutamide group. So my analysis kind of focused on those two groups as there was only 11 patients on apalutamide and enzalutamide each. So when we looked at Abiraterone and darolutamide, the baseline characteristics for hypertension, hyperlipidemia, and diabetes that were existing prior to initiation of the novel hormonal therapy were about the same. And when we looked to see how many patients developed, as a proxy for development of the condition, we looked at new starts of antihypertensive medication, new start of hyperlipidemia medications, and new starts of any form of diabetes medication. So when we looked at new starts of medications, we found that in the Abiraterone group, the percentage of patients that were starting new antihypertensives or new hyperlipidemia medications were quite a bit higher than those in the darolutamide group. However, interestingly, when we looked to see new start of diabetes medications, those numbers were about the same. And I was kind of asking myself why this might be, and I think it could be because I was just thinking, in the oncology clinic, how often are we checking hemoglobin A1Cs? It's really not ever or often at all for most of the providers I've been in clinic with as a fellow at least, and I don't routinely check A1Cs on my patients as well. We usually assume that the primary care physician's doing that. So we may see like multiple elevated glucose levels, but as long as it's not, above 250, 300, we're probably not acting on it. So I think honestly, we may be missing, detecting someone's newly developing diabetes and starting medication. And then we have patients that don't really follow with their primaries when they're seeing an oncologist because they're just very focused on their cancer. So maybe we're missing something there.